It's a pleasure and an honor to be here, and a challenge to follow Maureen, who is one of my heroes, and also a challenge to speak with Atul Gawande in the audience, one of, I think, the most important people in all of healthcare, and I'm thrilled about the collaboration that you've started with Atul and his remarkable team. This is my second time in South Carolina in about a year. I had a chance to spend a couple of days in Greenville and enjoyed that immensely, and now deeply understand your hospitality and your striving for excellence. So it's really wonderful to be part of this. My goal in an hour or so is to lay some context down, to really talk about where the patient safety field is and put it in a little bit broader context where it sits in relation to quality, value, cost reduction, some of the things Maureen's already begun to hint at. I noticed that the theme of the meeting is transformation, and I think with transformation is this notion that anything is possible. And so let me start off by showing that anything is possible. Here's my son at the World Series last year when the San Francisco Giants became the world champions. I expect this not to happen again in my lifetime, but it was pretty cool to be part of it. So dreams do come true sometime. I show this to you in part to remind me to tell you a story about my son, and I do this because my sense is I come from a big academic medical center in San Francisco, and some of the other speakers you'll hear from do the same. And I think it's often logical, if you don't come from that kind of environment, if you come from a community setting, which I think most of you do, to wonder whether or not we have anything to teach you, or we're sitting in this kind of highfalutin silo. And I worried about that myself, frankly. I did because I grew up in a family, I grew up in New York, and my father was a small businessman. My parents combined had one semester of college between them. My father ran a small garment business. And I remember growing up, we would talk about money all the time. My father had a lot of cash running around through the business, and we would sit down at the dinner table and talk about how money was working. And that seemed quite natural to me. And then I grew up and got married and had my children, and I got a little bit worried about them because my kids were growing up in this environment where dad was an academic physician and mom was a medical editor, and they were seeing a very, very different slice of the world than the one I had grown up with. It seemed a little bit too precious and highfalutin. And so when my son was about 10, we were walking around downtown in San Francisco, and I saw a condo building that was under construction. And if you're a parent, you know this, you look for these teachable moments, these chances to make a point that the kid will remember forever. So I saw mine and I said, Douglas, let me tell you something really pretty amazing. Before the condo is even completed, before that building's completed, they have to set a price. They have to guess as to what the price of an individual unit would be. And I explained the way they set that is they look at comparable buildings and they look at the location, the view, and those kinds of things. And then they guess at the price. And then I said, what do you think happens if nobody wants to buy it for that price? I thought it was a great chance to teach about supply and demand and the laws of capitalism. And he looked at me and he scratched his head and he said, did they get a grant? And I said, we are in deep trouble here. So I tell you that because I get that the activities that we are asking you to do, I mean, Maureen has challenged all of us to try to get at this triple aim. And there are some generous funders around, and there are some grants around to do some of this work, but most of it won't be funded that way. Most of this will come from your bottom line, and you're going to have to make very, very hard decisions about priorities and values and what's important, and those decisions are different than the ones you might have made 10 years ago. And some of the subtext, I think, for my talk is that 10 years ago, if you were a really ethical doctor, nurse, pharmacist, hospital, or healthcare system leader, you might have cared deeply about safety, quality, and yet not made the requisite investment because there were really no political or other forces pushing you. And ethics is very important, professionalism is very important, but in my experience, it's not enough to drive the kinds of system changes that are necessary here to get done what we have to get done. The environment we operate in now is very different than that, and I think in many ways very exciting because we are being driven to do these things. And so the ethical compulsion that we have to get it right is now being joined by a group of other forces, and that's really what I want to talk about with you today. So I said I wouldn't have guessed 10 years ago that, that the Giants would win the series, that's for sure. I would have guessed this, and this is that we would be moving toward value. And I think about value as quality and really in some ways all of the IOM goals. Patient satisfaction, the patient experience, quality, safety, all the good stuff, divided by how much that costs. I show you here a Toyota Highlander Hybrid. This is a car we bought a few years ago. This is an SUV without guilt. This is the big car that can cart the kids around, but you feel okay because it's a hybrid. When we bought this, I can tell you that we are not wealthy enough to buy the best car, nor are we cheap enough to buy the cheapest car. We bought it based on those two things. We bought it based on the quality and our perceived quality of this car divided by its cost. That's how we buy everything. That's how we buy our clothes, where we go on vacation, where we send our kids to school. The only exception to that has been healthcare. And if you really want to take the wide-angle lens and look at what's happening, what you're seeing is a very rapid movement toward the end of healthcare exceptionalism, where a group of stakeholders really coming at us from many different directions are driving us to make decisions based on value. And really it gets at the triple aim, to try to figure out what are the groups, what are these set of incentives and policy initiatives that will drive an end toward healthcare exceptionalism, drive us toward providing the highest value care. We demonstrably don't now. I think that, and that's not clearly what we've learned, is that's not because we don't work hard enough. We work plenty hard, but for a whole variety of forces that Maureen already hinted at, we don't deliver the highest value care. And I think you can see what's been happening over the last 10 years as a group of fairly chaotic efforts to try to move us toward delivering the highest value care and making us accountable for that. What I wouldn't have guessed is how quickly this has happened. So I kind of knew this was going to happen 10 years ago, but I would not have guessed that things would come as rapidly as they've come at us in the last 10 years. So as I think about the healthcare world, I'm going to wander a little bit because I don't see this very well, so let me move up here. Still hear me okay? Yep. So as I think about the healthcare world in the transition from Clinton to Bush, only 11 years ago, this to me seems like the landscape. Quality and safety were assumed to be excellent. We all believed that healthcare was pretty good. There was no business case to improve quality and safety. Nobody understood how to improve quality and safety. Maybe Maureen did, but she may have been the only one. There were very few people who thought about healthcare this way. There was very little research to help us along. There was very little concerted effort by any healthcare system to improve quality and safety. And the combination of the wrong mental model, and I think the wrong mental model was that we believed quality and safety were individual manifestations, were flowed from really smart doctors and nurses trying their hardest, and that delivered quality. And as I listened to Maureen, it's just so glaringly obvious that the attributes of these systems that she highlights that are really leading the way, and some of the ones I've seen around here, it doesn't have all that much to do with the brilliance of the individual physicians. It really has so much more to do with the way the system works together, teamwork, collaboration, and some of these principles that we've drawn from other industries about how do you improve flow and change systems. So the results, I think, were quite predictable. I want to take you through a timeline of the last 11 or 12 years to demonstrate how much change we have seen in a relatively short period of time. Now, you may say 10 or 11, 12 years, that's not that short a period of time, but trying to change the direction of a battleship, which arguably healthcare is a very big battleship, being a sixth or seventh of the economy, as complex and fragmented as it is, that's a big deal trying to change it. I have been staggeringly impressed with how much has happened, and I think it's only in taking a step back and reflecting on this, because we're all overwhelmed with our inbox and our Twitter feeds and all that kind of stuff each day. It's hard to kind of take that step back and think about the landscape and how it's changed. So let me take you briefly through this tour. To me, this is the start of the patient safety movement, the Institute of Medicine report on medical errors, To Err is Human. It only came out 11 years ago, not very long ago. In a few minutes, I'll spend more time talking about more specifically what's happened in safety, but I'm speaking now more broadly about what's happened in safety and quality in this entire environment. So that's only 11 years ago. It first came out in December of 1999. A year or so later, the IOM's companion report on quality, called Crossing the Quality Chasm, came out. And as Maureen was talking about, the 6 aims, which seems very natural to us, that was all brand new. That was introduced to us through this report. This is a picture of a retractor inconveniently in someone's chest. And it's meant to remind me that the National Quality Forum, which is the organization that has come up with the list of never events, things that should never happen in healthcare. National Quality Forum was only constructed in 1999, and it produced its first list of never events in about 2002, 2003, only about 8 years ago. Here's Beth McGlynn. Beth's study in the New England Journal in 2003 that demonstrated that we get it right. We deliver evidence-based care 54% of the time, close enough to a coin flip to be quite memorable. That came out in 2003, again, only 7 or 8 years ago. The Joint Commission, I'll talk a little bit more about this in a few minutes, but the Joint Commission wasn't invented in 2003 or 4, but it was reinvented in 2003 and 4 with the beginning of the National Patient Safety Goals and the movement toward unannounced surveys, which I'll talk about in a few minutes. But that sort of the main accreditor of American hospitals in about this era looked at the way it did its business and said this is woefully lacking if our goal is to try to improve safety. This is hospitalcompare.hhs.gov. This is the first federal reports of quality data. And now I can go on the web and in 10 seconds find much of your quality data from any of your hospitals. That was just launched in 2003. Also a relatively recent phenomena, using transparency as a way of demonstrating quality results and driving systems to change. And I'll talk again about how well that has worked. Here's Don Berwick. And I show him here in 2006 in the timeline. Don, of course, along with Maureen and others at IHI, have been working on this for 20 years before that. But in 2006, around this time, was the campaign, the 100,000 Lives campaign, which to me was very important evidence of the ability of all of us to work together to collaborate on a set of goals, something that really hadn't happened previously. Here's Peter Pronovost. Peter, another one of my heroes, is a professor at Johns Hopkins. In about this year, 2007, 2008, he published the results of his checklist study that looked at the change in catheter-associated bloodstream infections in more than 100 ICUs in Michigan. What I think Peter's study really did was it pointed the way toward a large scale, in this case a statewide collaborative, looking at the imposition of a set of standard practices, very importantly, and I think Atul will be the first one to say this, very importantly combined with leadership engagement, combined with teamwork improvement. It's not just a checklist, but it's a much broader set of activities that led to really staggering improvements in the quality of care and the safety of care in ICUs in Michigan. And also, I think very importantly, there was a measurement piece of this that I think was useful in that demonstrating hard data showing decreases in harm, I think helped fuel other initiatives, including the one that you're launching today. This is Atul Gawande, and you will meet him later today. I show Atul here. I could have shown him many places along this curve because he's been so influential in so many ways. But his article in the New Yorker on the cost conundrum, this is the one that compared two towns in Texas and showed wide variations in the costs of care that didn't seem to line up with quality or outcomes, was extraordinarily influential because it was really the first time, something Atul does I think uniquely well, is take data and information that was available, this was the Dartmouth Atlas data, but kind of wonky and a little bit arcane and not accessible to the average person, and tell stories in a way that made it incredibly visceral. And I think, as you probably know, this became required reading in the White House as part of the movement toward health reform. This is David Blumenthal, who's just stepping down from his role now as federal IT czar. I show David here because David has had the nice opportunity to spend $20 or $30 billion trying to promote information technology implementation through the meaningful use standards. I show it here mainly to demonstrate that David's job, the job of the Office of the National Coordinator, is only also about 7 years old. So under the Bush administration, an Office of National Coordinator for Information Technology was formed in about 2003, 2004. And so it's only been 6, 7, 8 years that the federal government has said we need some coordination function for this humongous project of trying to wire American healthcare. And David, I think, has done an extraordinary job. And here I have Don shifting roles to become director of CMS. And in only 8 or 9 months in this job, and as you probably know, the politics of his present position are fraught, to say the least, but he's also done, I think, a remarkable job in moving the organization from being what I think typically we call a dumb payer, someone who just, you send a bill in and they send you a check, to an organization that is committed to doing what it can to try to improve quality, safety, and efficiency. The reason I sort of highlight all this for you is just to demonstrate what an incredibly short timeline this is, that none of this was in place prior to 11 years ago. To simplify it, I think these are what I take from the last experience of the last 10 or 11 years. An extraordinarily rapidly growing business case for quality and safety, steady progression from what you see in the beginning. The Institute of Medicine has no power. So you see in the early days simply putting it out there, making the case that we need to focus on safety and quality in a new and more vigorous way. Social pressure. The IHI has tremendous influence, but also has no power to make anyone do anything, and yet took advantage of its extraordinary credibility in the field to get thousands of hospitals to sign on to initiatives. And then you also have the increasingly powerful organizations, for example, the Joint Commission. But even the Joint Commission's engagement in this area, it's pretty hard to fail a Joint Commission survey. They can make your life a little miserable, but most people will pass at the end of the day. So you have accreditation with relatively low chance of failing. You have transparency. Sure, your hospital data were reported on Hospital Compare, and yet there was no evidence that any real person was looking at those data in making a decision about whether to go to your place or the place across town. So you have relatively wimpy stakes in the beginning, but you see the senses that they're growing and growing in power, in persuasiveness, and ultimately in compulsion for us to focus on safety and quality. What I think we've seen in the last couple of years is the addition of payment changes on top of all of these other sets of pressures. And that may turn out to be the largest game changer of all. You've seen now tremendous capacity building, and I think this conference is just one example of that. You see organizations from all over the state coming together, trying to say, what can we learn from folks from the outside, but probably more importantly, what can we learn from each other? Who's doing things that might be applicable to our organization? That didn't exist 5, 7 years ago, so that's all pretty new. Transition, and I think the AAA really gets at this, a transition in the last 2 or 3 years, and I'll talk more about why, from a fairly narrow focus on the numerator of the value equation, quality, safety, to some extent, lesser extent, the patient's experience, to a recognition that if we do that but don't also focus on the cost part, we're not going to make it, that the cost part is vitally important. So a shift from quality and safety to more this overarching notion of value. And I think one of the most exciting things I've seen in the last couple of years is a recognition that you will not be able to succeed in this environment by dealing with this project by project. I think that was not true 5 years ago. If you were being pressured to all this to try to figure out how do we make sure that a patient with pneumonia gets a flu vaccine before they leave, you could probably have approached that relatively successfully by hiring a pharmacist, hiring a nurse, coming up with some system that didn't change the way anybody did their work. You just added on some appendage and you got that thing done. But the number of things that you now need to do to succeed in this environment is so broad that I think now we have hit that tipping point where there's a recognition you will not be able to succeed in this environment by doing business the way you always have. You actually have to transform the way people think about the work, their relationships with each other, and the way the entire organization functions. This is a publication that I don't read that often, but every now and then is kind of interesting to read. This is the actuarial state of the Social Security and Medicare program. It comes out every year. It's not as scintillating as a Gawande New Yorker article. I just warn you in case you feel compelled to go look at it. But this one I thought was particularly interesting, and in many ways was as compelling. This talked about how the Medicare trust fund is going to go broke, and we were all pretty familiar with that. Let's see, I can't read this very well. Let me walk over here. So the projected exhaustion of the health insurance trust fund within the next 8 years is an urgent concern. So this came out in 2009. That means by 2017, in plain English, that means Medicare will be broke. Now, in case any of you become despondent about that, though, we can fix this. So calm down, it's okay. Same report goes on to say the health insurance trust fund could be brought into actuarial balance over the next 75 years by changes equivalent to an immediate, meaning today, 134% increase in the payroll tax, or an immediate 53% reduction in Medicare expenditures. And if you think either of those are too draconian and not politically possible, it turns out, or some combination of the two. That'll get us there. Obviously, none of these are not possible. These are not feasible changes. And so this is the daunting problem that we're faced with today, and this is not going away. And we're beginning to see evidence of the way that's beginning to play out through the system, as you see even what's going on in Wisconsin or some of the debate that's going on in Washington now. It's increasingly about these numbers that can no longer be denied or pushed back to deal with next year. Now, what does that mean for us in terms of very tangible changes in payment policies, transparency policies? It's a pretty big deal what is about to hit us over the next few years. We've only gotten the early, we've seen the early pieces of it are beginning to hit now, but over the next 3 to 5 years, this is going to become very tangible very quickly to healthcare organizations and hospitals and physicians as well. What I've laid out here is 5 or 6 different initiatives that Medicare has planned. These are not possibilities unless there is major political pushback and major changes. These will be in the payment landscape within the next 3 to 5 years. I won't go through all of them. I do want to spend a little bit of time on value-based purchasing. Hospital-acquired conditions is the euphemism for adverse events that we are no longer being paid for. That was launched a couple of years ago. It's growing. The readmission initiative you know about, that the chances that that a patient with Medicare who's discharged from an American hospital will be readmitted within a month is 20%. That's staggering. If you happen to have heart failure, it's 30%. And it's very clear from the evidence, including some that IHI has helped generate, that we can easily have that with a number of pretty simple to implement initiatives, but we just didn't because there was no skin in that game. That's changing. A lot of other initiatives. The bottom line is extraordinary. The bottom line is that within about 3 or 4 years, somewhere between 7 and 10% of your Medicare payments will hinge on your performance. All right? Up until recently, none of your Medicare payments hinged on your performance. Medicare was a dumb payer. You sent a bill in, they sent you a check. 7 to 10% of your payments will hinge on your performance. A hospital that's doing extraordinarily well in American medicine now, who's having a banner year, has a profit margin of 3 to 5%. There are very few hospitals in this country that could survive a 7 to 10% in Medicare payments. But if you are not performing in quality and safety, that is what you're looking at within the next 3 or 4 years. That is a major change. That means this is no longer elective. We've had several years where we've been driven partly by maybe this is going to happen eventually, but a lot of it has been driven by our ethics, our feeling like it's the right thing, enthusiasm for it. That's terrific, but this is now, we're moving from the elective to the mandatory stage. I'm going to show you something I saw at a conference run by the Prescaney Company recently that made this more tangible than anything I had seen previously. I have no financial arrangement with this company. It's just something that I'd been reading about value-based purchasing, but I didn't quite get it. So let me show you the way it's going to work, because it makes, I think, more clear than anything I could tell you how real this is going to be for hospitals in South Carolina and elsewhere. This is something called, they developed something called the prototype calculator summary page. And what it basically says is Medicare, starting pretty soon, rather than giving you all the money that they owed you, will instead withhold about 2% of that money each year. and you can earn it back depending on your performance. And if you are perfect, if you perform perfectly well, you will earn back all the money they held back. So it was an interesting change in thinking about this. From when I used to think about pay performance, I used to think about, okay, this is a bonus payment above what we used to get, and that will obviously have to be matched by some cuts to the losers. And so, but ultimately it'll be net neutral. It is not going to be net neutral. It's going to be, the money has to be cut or Medicare goes broke. And so the way this is going to play out, it's increasingly clear, is that perfect performance will allow you to continue getting what you were used to getting. And anything less than that will lead to significant cuts in what you receive for the care you deliver. And I'm assuming not just from Medicare, but from all payers. This is the way it works. So they will withhold 2% of your payments. You can earn it back based on something called your value-based purchasing score. Now, your value-based purchasing score is a conglomeration of two pieces. One is your performance on clinical measures. This is the stuff that's reported on Hospital Compare. This is, did you give the beta blockers and the aspirin for the patient with a heart attack? What was your door-to-balloon time? What's your readmission rate? What's your hospital mortality rate? The things that we're used to seeing in terms of clinical quality measures. In addition, there's a significant piece of it that will flow from your patient satisfaction survey scores. So there's a standard tool instrument that's sent now to a random sample of hospital discharge patients in the country. And based on your scores on those surveys, that will also roll up into this value-based purchasing measure. The way that measure will be constructed will be a 70-30 mix of your clinical scores and your patient satisfaction scores. So those of you who used to think this is really all about clinical quality, patient satisfaction, that's kind of nice, but that's not real clinical medicine. We have to focus on the clinical piece. 30% of your overall score will come from the patient's responses on those surveys. That's a very big deal. Here is one particular hospital that they kind of made up that had a clinical score of 65 out of 100, a satisfaction score of 48 out of 100. Rolled up, that turns out to be about a score of 60. What that means essentially is if they were getting $100 million a year from Medicare, Medicare will withhold about $2 million of it, and they would have earned back about 60% of that, leaving 40% on the table. So now these are relatively big numbers that none of us had to confront before. I asked them to run my hospital. This is UCSF Medical Center in San Francisco, and you can't see this, but a couple points I want to make from this. Our score was about 57, which is sort of middling. It's not great. It turns out our clinical score was, I think, 71, pretty good, but our patient satisfaction score was not that hot. I think it was 26 or 7 or so, and rolled together, this is 57. So that's where we are. We would have earned back 57 or so % of what they held back from us. What they showed me, when Preskini ran this for me, what they showed me was for each score, for each clinical quality measure, did we give beta blockers, did we give aspirin, our door-to-balloon time, there was a, that's a little loud, hang on. There was a measure associated with it that then had a dollar amount associated with it. For each one, a certain amount of money was withheld, and depending on our performance, we could make that back. And that was true for each patient satisfaction question. So I'll just blow this up so you can see a couple of things. This is pneumonia question number 6, initial antibiotic choice for pneumonia. And there are guidelines about what the right antibiotics are for pneumonia. Our score was 87. 87% of the time we gave the right antibiotics for pneumonia. That wasn't near the top percentile, which is where we needed to be in order to earn back the money. They held back about $110,000 from us, and they kept all of it. We didn't earn any of it back because of our score on that one measure. On patient satisfaction, HCAHPS questions 1 and 2. 1 is how good was communication with your doctor. Second was how good was communication with your nurse. On both of those, we were not at the threshold to earn back the money. Each question was associated with a withhold of about $61,000, and we earned back none of it. So we left $122,000 on the table because of the responses that patients had to their communication with doctors or nurses. So this is making this very tangible in a way that did not exist before. It turns out, this is a pretty cool tool. It turns out that with your mouse, you can actually grab your line where you are, and you can shove it over a little bit to see what happens if your score on this question 1 had been better, or your performance on pneumonia had been better. And as you move it around, the numbers flicker. So you can imagine chief financial officers will have hours of fun sitting there moving the little toggles back and forth, watching the changes in their revenue. Now, I believe that pay for performance and changes in the payment system are not the most important thing that drives us. I really do believe that we are driven because we want to do the right thing, and there are other pressures like accreditation and transparency that I'll talk about. But what has become clear just in the last couple of years is the degree to which these kinds of payment changes are real, tangible, and are going to be influencing the success of the systems that we work in. That's sort of I wanted to give you a little bit of a big picture context for where all of this kind of fits together, because I think we can look at safety in a more narrow way, and that's what I'm going to do now for the next 20 minutes or so. But I think you need to understand that safety is part of this broader context of safety and quality, which is part of this broader context of value. And we are in this environment where we are being pushed, I think quite appropriately, to try to figure out how do we deliver the highest value care, the best quality, the best safety, the most satisfying experience for patients at the lowest cost in a way that is no longer elective. And if we wanted to have kind of time to get ready for this, because it takes time to integrate and to build IT and to change culture and to teach people about systems thinking, I hope you've been doing that, because the time is up. It's now, this is hitting the fan. All right, so I've already mentioned the IOM report, and you may remember how the Institute of Medicine report really started the safety movement. It started it by taking data from the Harvard Medical Practice Study done a decade earlier, doing a little fancy statistics, and coming out with the estimate that between 44 and 98,000 Americans die each year from medical mistakes. That, I think, would have gotten headlines for a day if the IOM had left it at that. The IOM went on and engaged in the most masterful bit of spin I've seen in my entire life in healthcare. They said these numbers, they're big, but they're a little bit bloodless. And they said, how about if we translate them into something that might be tangible to people? And you remember that, of course. They translated them into jumbo jet units and said the number of people that die from medical errors in the US would be the equivalent of a large plane crashing every day. And I think that analogy was masterful, because if you think about it for a second, what would we be doing to fix the problem of a large plane crashing every day? There would be no limit on what we would do, how we would change training, IT, regulations, and we would certainly close down every airport in the country for several days trying to figure this out. And as we think about what we've done in safety and quality, we've done a lot, but we haven't done that. So I think that analogy was very important, pushing us to focus on this in a way we didn't previously. I also like it because, well, let's take a little, see how many risk takers we have. How many of you would fly electively if you knew a plane would crash that day? We have a couple of people who say they would have it if it was 4 or 5 o'clock in the afternoon and one hadn't crashed yet. So you know, you would certainly think twice about it. And I think that's why I think the analogy was very useful. We needed something to get us unstuck and to think about our world in a different way, and I think the jumbo jet analogy did it for us. What were the problems? I've already hinted at some of these, but I want to make it a little bit more specifically about safety now. Our mental model up until that point was it was all about individual fault. That this notion of systems thinking was not something that was that any of us in healthcare had discovered, other than Lucian Leap, who discovered it 5 years earlier by going and reading the literature from error theory from other fields. None of us had any expertise. Certainly I think about my hospital. If I went around and said, who knows anything here about how to decrease errors, to think about improving systems, that was really not a core competency. We certainly didn't think about how other industries created safe conditions. None of us had any infrastructure that was at the local organizational level or at the national level. There was very little research. In 2001, I had the opportunity to be part of a project from the Agency for Healthcare and Research to analyze the state of the literature in patient safety. And it was really pretty weak. So even if you were an organization that said, we get it, we really want to go out and prevent surgical errors or diagnostic errors or medication errors, and you went to the literature, there wasn't a whole lot that the literature would tell you that you should do. Even if you say, I don't necessarily need peer-reviewed literature, I just want to know best practices, who's doing this work, and seeing great successes. Even there wasn't all that much data around to help us. I think very importantly, and I think IHI has been the leader here, there was very little understanding in healthcare of not just the science of safety, what should I do to prevent medication errors or falls, but also the science of implementation. The idea that there is a science about how you get complex organizations to change and get those changes to stick, that we had to learn, we knew nothing about until the last several years. So that I think has been a very important change. And as I've already mentioned, there was precisely no business case to invest in or focus on safety as recently as 10 or 11 years ago. There was always an extraordinarily powerful ethical case, but absolutely no business case. If you were a hospital CEO and you said, I have $1 million left over at the end of the year, I can invest in a new operating room or in marketing, or I can invest in safety. You were maybe making an unethical decision not investing in safety, but you were not making a bad business decision. And until that changed, we were really never going to get the traction that we needed to fix this. I want to spend a minute or two with you on my own view of what is work. So we're now 10 or 11 years into this, enough time that I think we're beginning to get a sense of which strategies have worked particularly well, which have worked less well than we had expected, some of the things that we can learn as we've tried things. Because I tend to think about life a little bit as, in a policy level. Not only are all of us learning how to improve throughput and decrease waste in our organizations, at a more macro level, we're also learning about how do we get this work done? What's the right set of incentives? What's the right policy environment to promote this work in the correct way? And I think we've learned a lot. I reviewed this in an article in the journal Health Affairs last year, and I went through 10 different buckets. Obviously, don't have time to do that now, so I'm going to focus on 4 of my favorites just to give you a sense of what's changed, what's happened, what I think has worked, and what hasn't. For each one, to be a little provocative, I gave it a grade, and my grade was my own sense of how useful each activity has been in promoting safety and quality, and largely safety now. So let's start with regulations and accreditation, which I give a B+, and I actually did a similar paper at the 5-year anniversary of the IOM report, and I actually gave it an A-. Now that may seem frankly un-American. In America, we hate the idea that someone else is going to tell us what to do. We like individualism, that's sort of a core value for all of us, and yet I really believe in this area, particularly in safety, we needed some central authority to create certain standards that we agreed to adhere to. Partly because we're terrible at this ourselves. This is something that does not come naturally to anyone in healthcare, and most of all physicians. Why did we need it? Let me give you one example. It's sort of a simple example of what happens without uniform standards. The Joint Commission, of course, several years ago began requiring that we mark the surgical site. Seemed like a reasonable idea. They didn't invent that. That was actually invented by a group of perfectly well-meaning orthopedic surgeons in the early 90s who was seeing cases of wrong site surgery and saying, this is bad, we have to do something about it. And they were very clever. Some of them said, I have a great idea. What I'm going to do is put a big X on the leg not to cut on. What's the problem? All right, that's clever, right? Because you'll see there's a big X there and you won't cut there. That's a foolproof solution. Other equally clever orthopedic surgeon says, I have a really good idea. What I'm going to do is put a big X on the leg that I'm supposed to operate on. And that way I'll just remember to cut right through the crosshairs. Now obviously it's just a matter of minutes before that will lead to an error. And so in this case, having some central authority, in this case the Joint Commission, say, I know you're all very clever, you'll come up with your own ideas, but there should be one way that we do this thing. I think that was very important. You might ask, why didn't we do that ourselves? You probably know this old saying about the medical staffs. The saying goes, what do we call a 99-to-1 vote of the medical staff? And the answer is a tie. This is not a core competency of physicians. The idea that we will come together and agree on a standardized way of doing something that should so clearly be standard. And I think we're still working through this. I think in Atul's program that you'll talk about later, this is a core issue of how do we get everybody to do the same thing, even as the evidence has emerged that it's the right thing to do. It's an extraordinarily tricky thing for everyone, but physicians in particular, this is not something that we're good at. The Joint Commission also improved its process, I think, tremendously. I mentioned this to the physicians yesterday, that until about 2003 or 2004, we got between 2 and 3 years notice of the day the Joint Commission was coming to inspect us. On that day, at least at my hospital, the floors were really waxed beautifully. All the medications were locked up. To me, it was by far the most dangerous day in my hospital. The floors were slippery as hell, and nobody could find any of the meds because they weren't where they usually were. Starting in about 2003, the Joint Commission began unannounced surveys and began the tracer method where they run around the building talking to people. It's not perfect, but it's much, much better, much more real than what they used to do, and I think to their credit. What's the problem and why I downgraded this in my own view over the last 5 years? The problem is essentially a quintessential problem with a centralized regulatory or accreditation solution. It's pretty good for low-hanging fruit. If you're saying, let's get rid of high-risk abbreviations, and it doesn't really matter whether it's in South Carolina or California, we should not use 10U insulin because hundreds of patients in the country have died when that has been mistaken for the number 100. Everybody should do that. It should be standard. The same thing I think is true of sign your site, things like that. So it's pretty good for process changes that are pretty immutable and don't vary very much across different sites, sizes, locations. The problem is that as a rule, those sort of centralized solutions tend to run out of gas when you get done with the early low-hanging fruit. And if you look at the Joint Commission's National Patient Safety Goals, in the early years, they were sign your site, high-risk abbreviations, things like that. The last couple of years, they have been in leadership standards, dealing with disruptive providers, medication reconciliation, things that are much more nuanced, much more sociocultural, probably are very different implementing them in a 60-bed rural safety net hospital and my 600-bed academic medical center. And in those areas, and I think the checklists and surgical safety are probably more like that. It might seem like we can just make this a national standard that what big deal, you check a few boxes. But as you'll hear later from Atul and his team, this is extraordinarily challenging in that it's much more than just a set of boxes. It's a sociocultural experience. And if you read the checklist manifesto, which I hope you all will, you really come away with this deep understanding that this is a culture change and communication vehicle much more than a process change facilitator. And in those areas, a centralized regulatory or accreditation solution tends to have fairly limited efficacy. So I think we're moving from a stage where having the Joint Commission tell us, thou shalt do X, was really important because we needed somebody to tell us, and we stink at that ourselves, to a stage where that becomes a less important part of the solution than probably other forces that are going to make us want to improve, but then some autonomy at the individual level, or maybe in your case at the state level, where we figure out the best solution for our own circumstances. Reporting systems. Reporting systems have been a very interesting phenomenon to watch. When the safety field launched 10 or 11 years ago, one of the things that we did was we looked to aviation. Aviation seemed to be the best example of an industry that had their acts together, had extraordinarily low rates of at least serious errors and harm. And I think that's been useful. I think some of the things we've learned from aviation about teamwork, standardization of the cockpit, the use of simulators has been very valuable. On the other hand, this was an area where the analogy didn't work. The analogy in aviation was, in aviation there is something called the National Aviation Safety Reporting System. Any near miss basically must be reported to it. It's analyzed really quite well by a central group, actually run by NASA, that's reported out. They have some regulatory authority through a link to the FAA. They can close an airport, they can shut down an airline. They publish a newsletter that everybody reads. And we said, wow, that seems to work really well. We should do the same thing in healthcare. We should have everybody report everything. Here was where the misanalogy came. In the entire year in the United States, the aviation safety reporting system across all the airlines will get about 40,000 reports. My one hospital this year will get about 20,000 incident reports. And believe me, we don't report everything. If we reported everything, we'd get 500,000 to 1 million reports. My hospital is one of 6,000 hospitals in the United States. And then there are the clinics and the skilled nursing facilities. The notion that reporting everything is a good idea was silly, was kind of naive. There are other sort of analogy flaws as well. The other being that aviation, of course, doesn't need a reporting system for hits because it has CNN. And so, so really all they are looking at is reporting near misses and unsafe conditions. We've got all of that plus hits that would otherwise not be captured. So I think this is an area that we don't understand very well, and is really ripe for new approaches and new ideas. Clearly, systems need ways of finding out what's going on under the hood, and when there are unsafe conditions, figuring out, learning about them, fixing them, learning from those efforts. On the other hand, millions of reports flowing in, which happened in the state of Pennsylvania, which required that every hospital report everything, which happened in the United Kingdom. I think virtually all of those systems have said, this is data overload, we actually don't know what to do with it. So I think this is one where I don't think we got it right in the beginning, and I can't tell you what is the right way to calibrate it, but it's clear that reporting everything is not the right solution. Why did I give it a better grade? Because I think we have become a little bit more thoughtful about what kinds of things in safety might be publicly reported. And that's a challenging issue because it obviously has people get concerned about how this is going to look to the public and how it's going to play out. But I think it has led to some progress. Let me tell you what I mean and start by talking a little bit about quality. I already mentioned to you that hospitalcompare.hhs.gov launched 8 years ago, so quality data are now being publicly reported. And I have to say that one of the biggest surprises I've seen in the 8 years since that time is how effective that has been in leading to change. So I don't know about your hospital, but I can tell you at my hospital, we do backflips trying to improve our performance on those publicly reported measures that are on Hospital Compare. What's fascinating about that is there still, in 2011, is very little evidence that any real people are looking at that data and making decisions about what hospital to go to based on that data. So if you'd asked me 11 years ago, will transparency work? I would say, yeah, I think it probably will if it breeds consumerism. What's clear is transparency works really well in healthcare, and its mechanism appears more to be our own pride or shame than, at least at this point, any clear movement toward consumer-driven choices based on those data. I think that's going to change over time. I think patients are going to get more used to looking at those data and make choices that way, but right now, that doesn't seem to be the mechanism. Because of this, because it seems to have worked fairly well, and if you look at the data on Hospital Compare and the performance of American hospitals on those data elements, it has shot up in the last 8 years. It's clear that people are responding to those measures. So you might then ask, well, why don't we use this in safety? How about just publicly reporting all of our safety outcomes? Well, there is a problem, and the problem is a scientific problem. The problem is, as I've mentioned, if I want to find out whether your hospital is any good at taking care of patients with heart attacks, I can sort of measure did you give aspirin, did you give beta blockers, what your door-to-balloon time is, what your risk-adjusted mortality is. If I want to find out whether you have a safe hospital, I don't really have any parallel measures that I can go to a chart and in a replicable way look at those measures and then publicly report them. So there's a measurement problem. The one exception to that, I think, has been certain healthcare-associated infections, which is partly why they have risen up in the spectrum of the things we focus on in safety. We spend a lot more energy thinking about central line infections, for example, than diagnostic errors. I think diagnostic errors are probably the more important safety hazard, and yet we have no idea how to measure them, and actually not much of an idea how to fix them. And so because of that, these other things that are more measurable have tended to come up on the ladder. That's natural. Now, how do I know that we're not very good at measuring safety? I know because of this. I'll go to a hospital periodically, and they'll show me their curve, the number of incident reports submitted through their incident reporting system, and it's gone up 25, 30% in the past year. And any guesses what they say when it's gone up that way? Great. Reporting's better. And is that good? That's great. This is terrific. We're so proud of ourselves. We've been working on a reporting system. We've been trying to change our culture so people feel comfortable reporting. They have a sense that we're acting on the reports. We could not be more pleased, and I say, that's fantastic. You should be very proud. And then I go to another hospital, and their reports are down 25% in the past year, and I ask them, what do you think of this? We're doing better, right? look, we have 25% fewer errors in the past year. We're so thrilled that this is finally taking hold. Now, I have no idea which one of those are true. They could both be true. Neither could be true. This is a fundamental problem in safety that until we have strong, auditable, predictable measures, the ability to use public reporting as a tool to drive safety is quite limited. Why are they gaining momentum? I think the key was the National Quality Forum's list of never events. Now, that never events is also a little bit of a misnomer. When it was coined by Ken Kaiser, these were things that should never happen in healthcare. Cutting off the wrong leg, abducting a child being abducted from the hospital. He was not referring to a decubitus ulcer in an 80-year-old patient transferred to you from a skilled nursing facility, and yet that's on the list now too. So the list has gotten expanded, I think, beyond its original intent, but as a political matter, branding them as never events has created a lot of momentum to have us report them, to have that publicly reported. It has led to the No Pay for Errors initiative around these errors. So I think it's actually been a useful construct. Most states now require that these never events are reported to the state. The key to that, I think, at least in my experience, has not been that the state is doing anything so wonderful, analyzing the reports, reporting them out. Certainly in California, that's not true. What has happened, though, is knowing that when we have a bad error, we are going to have to report it to the state, and the state may come in and visit, has led us to really become much more active and aggressive about analyzing our errors. So we have completely revamped our root cause analysis process. It's almost just in time now. Something nasty happens. We have a standing weekly committee meeting of all of the key leaders in the hospital, basically as a vessel ready to do a root cause analysis from any terrible error that happened in the prior week. And I think that has been very useful. First hour is analyzing a bad error that happened in the prior week. The second hour is report backs of groups that have gone out to analyze errors in the past month or so, coming back to tell us whether they fixed it, what worked, what didn't work. So why did we do that? We did it because of the right thing, but partly because we were now having to report these to the state. And as I've already mentioned, CMS is now using this list to populate its No Pay for Errors initiative. I'm going to spend just one moment on healthcare IT. I give healthcare IT a C+. Now, the reason I give it a C+ is in part because it's not that it's gotten worse over the last few years, but as I look at the state of healthcare IT and I compare it to my iPhone and my iPad, it's just that much more jarring that I can, when I make my plane reservations or my restaurant reservations on OpenTable, it's so good in the rest of our lives and so clunky still in healthcare if you're lucky enough to have a fully functioning IT system. The early glowing studies, most of which came from Atul's institution, from the Brigham, I think we've learned were probably not as generalizable as we might have hoped. The Brigham has been working on this for 30 years, built its own system. That experience is a little bit different than what the rest of us have, which is buying a store-bought system, airlifting it in, turning it on, and saying, okay, fix everything. And we've learned it doesn't exactly work that way. As I mentioned yesterday at my hospital, we bought a vendor-built system, implemented it about 4 years ago, and a year ago decided to pull the plug on that system and switch to another one. The cost of that speed bump was about $100 million. And that's not that atypical an experience now. A fair number of places are going through a similar experience. We're also learning there's a new literature that's emerged on errors caused by clunky IT systems. So this is not as easy as it looks, and I think there's still room to go. That said, I think we're in an exciting era where, because of the federal stimulus money and because of everything I've already told you, I don't think the stimulus money is the only thing promoting healthcare IT. In an environment where you will not get paid if your performance doesn't meet certain thresholds, I think hospitals and healthcare systems are realizing we need to have really good IT or we can't get this work done. Final point I want to make is something I've been focused on a lot for the last couple of years, which is balancing no blame and accountability. And I think we're now at a new phase of the safety field where we're thinking about this in a different way. That's why I give it a C+. Not that we have figured it out, but at least we're beginning to tackle this issue in a more purposeful way. What do I mean by this? It was crucial when the safety field launched that we adopted the systems notion, the idea that it's mostly about bad systems, not about bad people. It was crucial for two reasons. It was crucial because it's largely correct, And we have come to understand that most errors and adverse events actually are system flaws rather than individual flaws. I think it was also politically astute. And politically astute because if in 2000, when the IOM report on safety came out, we said we want a national effort, a national movement focused on patient safety and on errors, and we left it at that, every physician, when they hear the word errors, there's a link blot test that goes off, and all that comes out is malpractice. That's all they hear, and they can't hear anything else. So if we had not, at the same time as we were launching the safety field, said it's not about that you're bad or about negligence, but it's largely about a system that is failing you, I don't think we ever would have gotten any buy-in, particularly from physicians. So I think it was both correct but also politically astute to frame the field that way. And we have come to know over the last 10 years that that was mostly correct. And a lot of the progress has come from improving systems, and I think the work you're talking about today in terms of surgical safety is just a perfect example of the mileage that we have gotten from thinking about this in a much more systematic way than we previously had. You know, implementing a terrific checklist and all of the things around it doesn't have anything to do with how brilliant the doctor is. Probably how brilliant the doctor is may be a negative risk factor for getting the work done, I'm guessing. It has to do with how well the system works. So this has been a really important change in mental model for all of us. Why do we need a systems approach? I won't go through this. This is just a picture of an intensive care unit at my hospital demonstrating to you, and I also always need to mention this was taken several years ago because we do elevate the head of the bed like we're supposed to. If you take a look at the complexity of this, it is absolutely staggering. And the notion, and this was our notion until 10 years ago, the notion that you can work in this environment and keep patients safe if you're really good, really careful, well-trained, is a cruel joke. I mean, how could you possibly do this safely if human beings were not embedded in a system that anticipated they would blow it and catch those errors before they caused harm? So the system approach has been correct and I think very, very valuable. What I was feeling about 3 years ago was in my mind was becoming increasingly uncomfortable with what felt like two conversations that were beginning to overlap and conflict. And they went this way. On the one hand, we had this no blame, it's the system, it's nobody's fault. It was kind of Oprah-like, little kumbaya-ish. And the other, you had this increasing pressure for accountability. You know, we're not achieving these aims that we need to achieve. Who is responsible for that, and how can we make them accountable? Which was certainly a little less kumbaya-ish. But for a little while, it was fine. I was capable of handling both these conversations independently. And then I felt like they began morphing together in my brain. As they morphed together, things got garbled. And I was trying to make sense of how do we move forward in an environment where we know that it's mostly about the system, and therefore mostly should be no blame, and yet there were certain things that appeared to me to be blameworthy. And I was grappling with that, and I'd heard and read about the just culture, and that sounded like a reasonable start in terms of identifying things, but then I'd go to hospitals and ask about how they were implementing just culture and what would happen, particularly when a physician chose not to follow certain safety rules, and they would almost always say, yeah, we're not up to that yet. That's next year's agenda, we're going to tackle that one. And I said, we're not where we need to be here. So how do I think about this? I think we're struggling with two competing epiphanies. On the one hand, we know that most errors are committed by good people trying hard, and you have to fix the system. But on the other hand, we know that the system produces the results that are not where we want them to be. And part of that is because of a lack of an incentive and a lack of accountability. And a lot of the efforts in the last 10 years have been designed to try to achieve that kind of accountability. What do I mean by accountability? I mean there are reasonable performance expectations that are applied fairly and similarly for everyone. If there's a transgression that gets a nurse fired but doesn't, the doctor gets a wrist slap, that's not a fair or just system. It's not all sticks. It's not a system that is, this is what will get you suspended, this will be what gets you fined. There are also a series of rewards for good performance and good behavior. In my hospital 2 years ago, we launched a bonus and incentive system that actually includes our house staff. Our house staff now get a $1,000 bonus at the end of the year for performance on certain safety and quality measures. It's been really very interesting watching the house staff get really enthusiastic about quality and safety. It's not really for the $1,000 bucks. It's really about the messaging that this is an important part of what you need to be part of. I think it's critical that no blame remain the dominant frontline culture. One of my fears about moving in this accountability direction is we will forget that, in fact, most errors are committed by good people and the system is the right approach. But I think we get ourselves in trouble when our instinctive answer for everything is it's the system. I think we need a clear demarcation of blameworthy acts, whether it's gross incompetence, disruptive behavior, and, very importantly, failure of people to heed perfectly reasonable safety and quality standards. And the question that we're really confronted with is, as a profession that's supposed to be self-regulating, are we capable of drawing certain lines and saying this is a behavior that we will not tolerate as a profession? My guess is if we don't do that, others will do it to us in a way that will be much more arbitrary and much more onerous. My favorite example, of course, is hand hygiene. Hand hygiene rates in American hospitals 10 years ago were about 10% in most hospitals. Over the last 10 years, because of a lot of different sources of pressure, most hospitals have gotten their hand hygiene rates up to the 50 to 70% range. Very few of them have gotten them up to 90%. When they say they're 90%, I usually don't believe them. It usually is that the audit method is the nurse manager of the floor goes out periodically and, like a bobblehead, is sitting there with her tally, and everybody knows during those 5 minutes to be on great behavior. It's very rare that places have gotten up to 90% in a true auditable way. What's interesting about that is I'll go to a hospital periodically and I'll say, what's your hand hygiene rate? They'll say 50%, 55%, and I'll say, what are you doing about that? And they say, well, we're approaching this as a systems problem. And I'll say, well, okay. And then I walk around the wards, and there are gel dispensers every 2 feet, and on every wall is a picture of clinical leaders cleaning their hands, looking like they're just having the times of their life. And I go to the computers, and on every screensaver is the nastiest wound with pus oozing out. And I say, you know, the system seems pretty good. And when they tell me that's a systems problem, I have to say my BS detector goes off. Because I do not believe that in 2011 we can say that failing to clean your hands before touching a patient is a systems problem anymore. It's an accountability problem. And I think our failure to grapple with this and tackle this is, in some ways, it's understandable. This is very difficult stuff, but a little bit shameful. And I think one of the great challenges we have is how do we draw these lines thoughtfully, fairly, but at some point we say this is not a systems problem anymore. It's an accountability problem, and we then begin to enforce that. When is that approach correct? This is from an article that I wrote with Peter Pronovost in the New England Journal last year. The practice is important, and we know it works. The systems have been fixed. Inevitably, there are systems problems you have to clean up before you begin enforcing this. Unintended consequences have been addressed. There always are some, and you have to make sure that you've thought about them. Providers understand the practice, its value, how you will audit them, and the penalties. Someone forgets to clean their hands once, we're human beings, that's understandable. They're counseled, they're educated about that, they're not suspended or fined. But at that point, and I think hand hygiene, we have reached that point, and it's an interesting discussion about checklists that I think you will have over the next few days. But at that point, I hearken to Kissinger's words. Kissinger once said, weakness is provocative. And I think in areas like this, we've been provocative for too long, and it's time that we begin taking this on more seriously. I don't want to sugarcoat it. This is really hard stuff. But I think we have reached the stage of the safety field where our failure to address this and our naming everything as a systems problem is actually getting in the way of our credibility. And others quite logically will look at us and say, you folks appear to be incapable of self-enforcement and self-regulation, so we will do it to you. The bottom line is this, as Peter and I wrote in the New England Journal, we wrote, no blame is not a moral imperative, even if it seems that way to providers. It most definitely does not to patients. Rather, it's a tactic to achieve ends for which we will all, I think, quite appropriately be held accountable. And so I think that's where at least my own thinking is on this issue, and I think this is where, for a state that wants to be a leader in this area, you have to tackle this issue, and it's hard but extraordinarily important. Where are we overall in the safety field? I gave us a B- after 10 years. Not bad. I would have given us an F 10 years ago, so that's pretty marked improvement. That said, when my kids come home with a B- from school, they still get a pretty stern talking to. So I think we still have a little bit of room to go. I want to end with a couple of last things. I've been going on long enough that I'm sensitive to some of you may be snoozing, so let me show you this one. I like this quote. "When my time has come, I want to go peacefully in my sleep, just like Grandpa, not screaming like the passengers in his car." Just give you a couple of thoughts about where I think things are going in the next few years. And I think I've already hinted at them. Value will trump volume. This is now a new world in which all of these ideas that ultimately, yes, we will be judged and will succeed or fail based on value, that's no longer sometime in the future. That is now. Pressure from stakeholders will drive change from many directions. And one of my concerns about this is there are so many things that we now have to do that the question is where we hold on to the bandwidth to do things, for example, like teamwork training that we may not be forced to do but may turn out to be fundamentally important in transforming culture. I think that's a growing challenge for us as the list of mandates grows and grows. There's going to be a lot of statistical measures of quality and safety. I still think, at least for the short term, the single horrible event, particularly one that makes the newspapers or the blogs, will tend to trump those statistical measures, and because of reputational risk or the fact that it may lead to the state health department coming in or the Joint Commission coming in or lawsuits. This one I think is vitally important. The organizational dichotomy of American medicine, the idea that you can have the hospital and the health system here and it manages the nurses and the pharmacists and the case managers and all that, and the docs live out here, and these are two independent worlds that at best are wary but collegial, but mostly are competitive and sometimes even confrontational. I don't see how you figure out how to provide the highest value care in that environment. It seems to me to be impossible. And that doesn't mean there's the end of private practice as we know it, but it does mean there has to be more linkage and more integration, and this is no longer going to be elective. Each side is going to realize that they have to do this to succeed, and I was struck as Maureen was presenting some of her data. The systems that have done this are either systems like Kaiser Permanente or the VA that organize themselves that way, or systems that are not organized that way fundamentally, but have figured out that we better, or we can't achieve the results that we need to achieve. What else is next? The physician as king, and I even mean you, surgeons, era is ending. Sorry, Atul, but because of all of the pressure for standardization, the fact that many, not all, but many physicians will work for systems, and institutions that have tolerated certain kinds of behavior, whether it's disruption or individual physicians saying, I don't want to play that way, I have my own way of doing things. Institutions will no longer allow value-sapping decisions by individual physicians. It will no longer be compatible with institutional survival, which will allow for the courage that's necessary to make some of these hard choices that we previously have not made. Everyone will have an information technology backbone, which will make data increasingly accessible, allow us to measure and influence physician practice out on the front line, and non-integrated systems, and by that I mean non-systems that don't have information that flows throughout the system across the continuum will not be able to succeed in this environment. And I think we're seeing the emergence of a new set of competencies and a new vocabulary. So I hear my residents talk in a language that to me would have been inconceivable even 10 years ago. The residents will, the medical students will talk about systems thinking. They'll say that's a systems problem. They'll talk about checklists. They'll talk about teamwork. They'll talk about the importance of leadership. To me, that is incredibly gratifying and absolutely crucial. We can't get this work done unless we have this new and shared vocabulary. And I'm grateful to IHI because I think that organization, Maureen, has done more to allow us to understand and think about that vocabulary than any other entity in the country. So let me leave you with this thought. In about 8 or 10 hours, I'll drive up to Charlotte and get on an airplane. And I will know that the food's going to stink, and I will know that it will be uncomfortable, but I will have absolutely no concern that I will be harmed in the process of flying back to San Francisco. And today, as I look at the hospitals that you represent across South Carolina, there must be tens of thousands of patients checking into the hospitals. They also know the food's going to stink. They also know they're going to be uncomfortable, but they are, I can guarantee to you, scared that they will be harmed or killed in the process of getting care. And I commend you on what you're doing to fix that. I think we've made tremendous progress, but I think we still have a ways to go until they have the same feeling checking into your hospital that I will have when I get on my airplane. Thank you so much for what you're doing and for your attention.